So welcome back to Paramedic Zach, Episode 2, Part 2, where we'll take a look at flashcards 11 through 20 in an in-depth review. Alright, let's jump back to question 11. What is your adult dose for amiodarone given to a patient with wide complex tachycardia? The answer here is going to be amiodarone at a dose of 150 milligrams over a period of 10 minutes. So when talking about wide complex tachycardia, with this question specifically, we mean ventricular tachycardia. You can have SVT with aberrancy, which is going to cause a wide complex fast rhythm. But for this question, ventricular tachycardia is what I am referring to. Traditionally, ventricular tachycardia will present in one of three ways. Your patient is either stable, unstable, or dead. If your patient is in ventricular tachycardia and is dead, then you're going to start CPR and defibrillate as soon as possible. You're also going to alternate boluses of epinephrine and amiodarone. If your patient is in ventricular tachycardia and is unstable but alive, then you're going to cardiovert the patient at 100 joules. Lastly, if you have a patient who is in ventricular tachycardia and is stable, that is not presenting with any signs or symptoms of shock, then you're going to use amiodarone at a dose of 150 milligrams over 10 minutes. In order to give amiodarone over 10 minutes, typically it's injected into a 100 ml bag of normal saline or D5W, that is 5% dextrose in water. Then using a 15 drop set, that is a drip set that delivers 15 drops per milliliter, you're going to give 2 to 3 drops every second. This is going to give your 150 milligrams over a period of 10 minutes. So what exactly is amiodarone? Well, amiodarone is a class 3 antiarrhythmic. See, your heart runs on a sodium and potassium pump. Specific channels suited to these molecules regulate the flow in and out of the cells. What amiodarone does is it sits in these channels and prevents some of the sodium and potassium from moving in and out of the cell. This slowing of sodium and potassium causes the entire pump to slow down, and it slows conduction through the heart. Additionally, amiodarone has beta blocker effects, which we learned in episode 1, relaxes the heart and decreases the heart rate. This is why amiodarone is known as an everything blocker. By blocking the sodium and potassium channels and then by blocking the beta receptors in the heart, it works to slow down the heart. But if for any reason it doesn't work and your patient becomes unstable, remember to cardiovert your patient at 100 joules. So question 12 was concerning a 29-year-old female presenting with abdominal pain and either Cullen sign or Gray-Turner sign. This question, of course, was designed to get you thinking of an ectopic pregnancy. So what exactly is an ectopic pregnancy? Normally, an embryo will implant itself into the uterine wall 6 to 10 days after fertilization. Ectopy simply means an abnormal positioning. One of the most common places for an ectopic pregnancy to occur is in the fallopian tubes. And unless you're doing some weird experiments, babies shouldn't be grown in tubes. Implantation in the fallopian tubes can cause the tubes to rupture. Now, 10% of these patients will be asymptomatic, that is, they won't present with any symptoms. The other 90% that do present with symptoms are typically going to present with vaginal bleeding and abdominal pain. This typically starts about 7 weeks after the completion of their last menstrual cycle. Rupture of the fallopian tubes can cause sudden severe internal bleeding leading to hypovolemic shock. For this reason, you want to keep your eye out for abdominal distension. You also want to keep your eye out for Cullen sign, which is going to be some discoloration around the umbilicus, and Gray-Turner sign, which is going to be discoloration along the flanks. This bruising can be a result of the internal bleeding. So make sure you're monitoring the patient's blood pressure, looking out for hypotension, and administering fluids as needed. Alright, moving on to question 13. When treating an adult patient in cardiac arrest, if you don't have amiodarone, you can substitute in lidocaine. Your first dose is going to be 1 to 1.5 milligrams per kilogram, and the second dose is 0.5 to 0.75 milligrams per kilogram. In addition to treating stable ventricular tachycardia, amiodarone is going to be our second med given during a cardiac arrest, after epinephrine. But what if we don't have amiodarone? Well, we can substitute in lidocaine. Lidocaine, like amiodarone, is an antiarrhythmic. However, lidocaine is a class 4 antiarrhythmic. Like amiodarone, lidocaine is a sodium channel blocker. Since your heart operates as a sodium-potassium pump, blocking the sodium channels will decrease cardiac conduction and prevent the heart from misfiring. Well, that is the hope anyways. This is done by raising the depolarization threshold, making it so that more electrical stimuli is needed in order to initiate cardiac contraction. This will help keep the heart from reacting to every little impulse it receives and spazzing out like your 8-year-old nephew. This spazzing would be recognized on the ECG as fibrillation. Alright, moving on to question 14. As ICP increases, the blood vessels will occlude. As a matter of self-preservation, the brain will order an increase in blood pressure. As a result, the carotid sinuses will order a decrease in heart rate. So ICP stands for intracranial pressure. An increase in intracranial pressure is commonly seen in hemorrhagic strokes and traumatic brain injuries. ICP is measured in millimeters of mercury, and a normal ICP is 5 to 15 millimeters of mercury. Bleeding within the brain from a hemorrhagic stroke or TBI exerts pressure on the skull. Since the space within the skull is finite, the bleeding begins to exert pressure on the brain's blood vessels. When the blood vessels become occluded, the brain can no longer receive oxygen. As a matter of self-preservation, the brain orders an increase in blood pressure in order to get more blood and more oxygen. The baroreceptors at the carotid sinuses sense the change in blood pressure and decrease the heart rate in response. Lastly, you may find irregularities within your patient's breathing. This is because as ICP increases, pressure around the respiratory center increases and can cause damage to this portion of the brain. So let's review. When you suspect an increase in intracranial pressure, you should look out for 1. Hypertension, 2. Bradycardia, and 3. Irregular respirations. These 3 things together are known as the Cushing's triad, and it serves as an indicator of increased intracranial pressure. So how can we manage increased intracranial pressure in the field? Well, the answer here is going to lie within our ventilation. We know from episode 1 that CO2 is a cranial vasodilator. As a byproduct of metabolization, we exhale CO2. Therefore, we can manage the ICP patient by ventilating them at a rate that maintains an end tidal CO2 of 30 to 35. Alright, moving on to question 15. What is your amiodarone dose for a pediatric patient in cardiac arrest? The answer here is 5 milligrams per kilogram. You can give this up to 3 times between your epinephrine doses. So cardiac arrest is always going to present with pulselessness. However, your treatment is going to be determined by what you see on the monitor. As far as a medic is concerned, pulselessness can present 4 ways on an ECG: PEA, asystole, VTAC, and VFib. PEA stands for pulseless electrical activity, and asystole is your typical flatline. Both of these involve no cardiac activity, and neither of these get amiodarone. VTAC stands for ventricular tachycardia, and VFib stands for ventricular fibrillation. Both of these involve some cardiac activity that often results in an inadequate filling and squeezing of the heart. VTAC and VFib, however, both get amiodarone. With pulseless VTAC and VFib, amiodarone is going to be the second medication given after epinephrine. As I mentioned before, amiodarone is a class 3 antiarrhythmic. It's an quote-unquote everything blocker. It blocks sodium, potassium, and calcium channels and is used in hopes of preventing the heart from misfiring. Again, the pediatric dose is going to be 5 milligrams per kilogram in between doses of epinephrine to a max of 3 total doses. Question 16. What is your adult calcium chloride bolus dose? So the answer here is 2 to 4 milligrams per kilogram, but I know that in some systems, giving the entire gram to your adult patients is standard practice. So what is calcium chloride? Well, calcium chloride is a mineral and electrolyte used to treat hypocalcemia, low calcium, and hypermagnesium. hypermagnesemia. Oh man. That is, these things are treated in the hospital. However, in the field, calcium chloride can be used to treat calcium channel blocker overdose and hyperkalemia, which is high potassium. Calcium channel blockers such as amlodipine and diltiazem are often prescribed for hypertension and cardiac arrhythmias. See, the way that calcium channel blockers work is by sitting inside a calcium channel and preventing calcium from entering. Normally, calcium that enters the heart through these calcium channels stimulates the receptors responsible for cardiac contraction. At the right dose, this effect can be very therapeutic. An overdose, however, can cause hypotension and cardiac arrest. We can potentially reverse some of the effects by flooding the receptor site with calcium. Calcium can also be used to treat hyperkalemia, which is high potassium levels. Potassium is also a mineral and an electrolyte, but it has a relaxing effect on the heart. However, an excess of potassium causes a sustained depolarization of the cell's membranes. This causes conduction abnormalities within the heart. This can cause the patient to present with heart palpitations, shortness of breath, chest pain, and nausea and vomiting. Hyperkalemia can be identified on an ECG by the presence of tall, peaked T waves. Normally, T waves are no taller than 5 millimeters in the limb leads and 10 millimeters in the chest leads. So if you have 2 or more leads that exceed these values and looks like this, it's probably hyperkalemia. And just as a bonus note, calcium chloride can also be used to treat an overdose of magnesium sulfate. Question 17. An endotracheal tube medication dose should be 2 times more than that of an IV dose. So why would I give a medication through an endotracheal tube? Although it's not ideal, some medications can be safely absorbed by the lungs. This would be indicated if an IV or an IO could not be established. Since the medication is not being directly injected into the bloodstream, we're going to need a higher dose. So the AHA, or the American Heart Association, recommends a dose that is 2 to 2.5 times higher than the IV dose. So what medications can you give through an endotracheal tube? Well, remember the acronym LEAN. L stands for lidocaine, E stands for epinephrine, A is atropine, and N is Narcan or naloxone. These 4 medications can be given through an endotracheal tube at a dose that's 2 to 2.5 times higher than that of an IV dose. Alright, moving on to question 18. An RR prime in lead V1 is most indicative of a right bundle branch block. First, let's review what a bundle branch block is from a segment from episode 1. A bundle branch block disrupts the electrical flow through the cardiac muscle. See, normally you'll have an electrical impulse that starts at the SA node, travels down to the AV node, and then spreads out through the bundle of His and the Purkinje fibers. Well, what happens during a bundle branch block is that part of that electrical signal is disrupted, either due to ischemia or cardiac tissue death, and needs to take an alternate route. That alternate route being longer than the original path of energy. This delay in current causes notable changes in your ECG, particularly in the QRS complex. So the additional time it takes for the electrical impulse to travel across the heart to where the block occurred causes the QRS complex to become elongated, usually greater than 120 milliseconds. Once the electrical impulse from the left side of the heart reaches the block on the right side of the heart, the right ventricle can contract. This pattern of left heartbeat, right heartbeat causes 2 distinct spikes on your ECG. If you look in lead V1, you will see an RR prime, that is 2 distinct R waves. And you should also note that it's possible to see this pattern in leads V2 and V3. Next we got question 19. So stable, regular, narrow rhythm tachycardias should first be treated with a vagal maneuver. Then adenosine at a dose of 6 milligrams fast for the first dose, and then at 12 milligrams for the second dose. So regular narrow rhythm tachycardias are going to be your SVTs, or your supraventricular tachycardias. That is a tachycardia that is originating from an impulse located above the ventricles. So what you want to look out for is 1, a fast heart rate that's usually greater than 150 beats per minute, 2, absent or hidden P waves, 3, a very regular rhythm, and 4, a narrow QRS complex. In order to return SVT to a more stable rhythm, we need to cardiovert. Cardioversion can be accomplished in one of 3 ways: autonomically, pharmacologically, and electronically. Autoconversion is aimed at stimulating your vagus nerve and are known as vagal maneuvers. Your vagus nerve is responsible for parasympathetic activity in the body, aka the rest and digest side of your nervous system. Stimulating the vagus nerve will hopefully have the effect of slowing down the heart. Probably the most common vagal maneuver is known as the Valsalva maneuver. The Valsalva maneuver is performed by taking a deep breath in and then trying to exhale against a closed mouth and nose. This is also known as bearing down, like you're on a toilet. Other methods of stimulating your vagus nerve include coughing, initiating a gag reflex, and your dive reflex, which occurs when you submerge your face in cold water. However, oftentimes the vagal maneuver won't work and you'll have to move on to pharmacology. The medication that we're going to be giving to our SVT patients is adenosine. Adenosine works at the AV node in the heart. It slows conduction time through the AV node by altering the electrical gradient existing within the heart's electrolytes. Adenosine is first going to be given at a dose of 6 milligrams, followed by a saline flush. However, if this doesn't work, you can give a repeat bolus at a dose of 12 milligrams with a rapid saline flush. The reason the saline flush is so important is because adenosine has an incredibly short half-life, roughly 10 seconds. This means it can decay before it even has a chance to get to the heart. A saline flush is going to help push the medication through to the heart and to the AV node. Lastly, adenosine has also been found to affect the SA node, reducing the number of impulses sent from the SA node to the AV node. Fun fact about adenosine is that caffeine works by blocking the adenosine receptors in your brain from being stimulated. Then when the caffeine wears off, all the pulled up adenosine overwhelms the adenosine receptors and you have your typical caffeine crash. Alright, moving on to the last question of this episode, question 20. When treating a confirmed STEMI, give heparin at a dose of 70 units per kilogram to a maximum of 4,000 units. An ST elevated myocardial infarction, or STEMI, is caused by an occlusion of one or more of the coronary arteries. The lack of blood flow causes ischemia and eventually cardiac tissue death. Heparin is a naturally occurring polysaccharide and is used as an anticoagulation medication. Typically, a coronary occlusion happens when plaque buildup within the lining of the coronary blood vessels weakens the inner wall, causing it to rupture. The plaque buildup, which has now been released into your bloodstream, contains a clotting agent, that is, it's going to cause the blood to clump together. As heparin is an anticoagulant, it can compete with these clotting agents, preventing further occlusion. However, as heparin is an anticoagulant, be sure not to give this medication to a patient who's bleeding. Alright guys, and that wraps up the last question of this episode. We have done 20 questions so far, and there's only 480 of them to go. Yeah. So make sure you hit the notification bell, as there will be many more episodes just like this one. And if you got anything good out of this video, do me a huge favor and hit the like button for the YouTube algorithm. It helps more than you know. And if you want to get these videos regularly to help you pass your exam, make sure you hit the subscribe button. If you haven't already, check out part 1 right here. And if you have, well, I'll see you next time.